Hello, I'm Lieutenant Commander Joshua Wong. I currently serve as a medical officer stationed at the CDC Dengue branch, and I'm here to talk to you about dengue. Dengue is the world's most common mosquito transmitted viral disease and is a major health threat in the US and globally. That's why our mission here at the CDC Dengue branch is to develop and promote evidence based strategies to reduce morbidity and mortality from viruses transmitted by Aedes mosquitoes. New tools are constantly being developed to fight dengue. Even though these advancements will continue, one of the most effective ways to reduce dengue's impact is through informed clinical care. Left untreated, severe dengue can be fatal in up to 13% of cases. However, when recognized early and treated according to the World Health Organization clinical guidelines, mortality can be brought down to less than 1%. That's why understanding and following these guidelines is essential. This training aims to familiarize you with dengue, World Health Organization clinical guidelines, and practical tools that help you to follow these guidelines and stay on track with patient care. So let's get started. Today, we'll be talking about what you need to know about dengue to keep your patients and your community safe. But let's start why you should care about dengue. If you've been following the news, you know that dengue outbreaks worldwide can quickly overwhelm health systems. This picture was taken in Honduras at a hospital that was treating dengue patients. On the left, you can see that the hospital was so overwhelmed with cases that they had to convert the chapel into a dengue ward to deal with the surge of patients. On the right is another picture of patients lining the corridors of the emergency room as they overflow. Although mostly considered a neglected tropical disease, dengue outbreaks are becoming more common and the spread of the disease is starting to occur in areas where it wasn't previously. In other words, you're more likely than ever to see dengue cases during your clinical career. So being able to recognize and treat dengue is important because you could save a life. But before we start on the clinical management of dengue, let's start with some of the background and epidemiology of these viruses. Dengue is the disease caused by any of four distinct but closely related dengue viruses, numbered 1 through 4. Infection with one virus gives lifelong immunity to that specific virus, but only short-term cross-protective immunity to the other 3 serotypes, meaning that individuals can be infected up to 4 times in their life. Most infections are asymptomatic, about 3 in 4. Among those symptomatic cases, the illness typically manifests after an incubation period of 5 to 7 days, and the early findings can be nonspecific, meaning that it can be difficult to distinguish from other pathogens. Dengue can be life-threatening, but there are specific warning signs that will reveal the patients that are going to progress to severe disease. These viruses are transmitted through the bites of infected Aedes species mosquitoes, such as Aegypti or albopictus, that carry the virus in their saliva. However, other, less common routes of transmission have been documented, including perinatal transmission from mother to baby, transmission through blood transfusions or organ transplantation, needle sticks, mucocutaneous exposure, or hospital and laboratory accidents, breast milk, or sexual transmission. The Aedes mosquitoes that transmit the virus are very common in tropical and subtropical climates and can lay their eggs in any standing water. You can see a picture of the mosquito in the upper left, and then some of the examples of these containers in the other pictures, such as a small tray on the upper right, and then on the bottom row, a potted plant, a children's pool, and a bucket. As you might notice, the Aedes mosquito can lay its eggs even in very small or compact recipients of standing water, commonly found in urban areas. Finding and removing every single recipient can be challenging, making the vector very difficult to control. So let's take a quick look at the transmission cycle. Once a person becomes acutely infected with the virus, they become viremic, meaning that the virus is replicating in their blood. During this period, a mosquito that bites them can become infected. Once that mosquito ingests the dengue-infected blood meal, it will replicate in the mosquito for 8 to 12 days before it can infect someone else, which is called the extrinsic incubation period. After the mosquito bites another person and transmits the dengue virus, it will replicate in that person for at least 3 days, but can be up to 14 days before that person starts to feel ill with the symptoms of dengue. Getting infected with the dengue virus, however, can have a range of different outcomes. 60 to 80% of dengue virus infections are actually asymptomatic or subclinical. Only 20 to 40% actually result in symptomatic disease. Among those with symptomatic disease, 95 to 99% have uncomplicated dengue, but 1 to 5% will progress to severe dengue. Among those with severe dengue, 95 to 99% will survive, but 0.5% to 5% will die, mostly due to inadequate clinical care. There are several risk factors that can predispose a patient to severe dengue, including age extremes, such as infants born to seropositive mothers and older adults greater than the age of 65, persons with comorbidities listed on this slide, like asthma, diabetes, obesity, hypertension, sickle cell disease, kidney disease, or patients taking anticoagulant therapy. And finally, we know that the second time someone is infected with dengue is the highest risk for severe dengue compared to the first, third, or fourth infections. When we think about dengue prevention, bite protection is the most important thing that we can advise for our patients. That includes using EPA-registered insect repellents listed on this slide. Also, wearing loose-fitting, long-sleeved shirts and pants can protect from mosquito bites. Finally, you can prevent bites by controlling the mosquitoes in and around the home by using screens on windows and doors if possible, and emptying and cleaning any item in or around the house where water can collect and might be an egg-laying ground for the mosquitoes. So let's take a quick look at the global burden of dengue. We know that dengue is the most common virus transmitted by mosquitoes worldwide. The map on this slide shows areas of the world where dengue risk is frequent or continuous in the dark purple, where outbreaks are sporadic or risk is uncertain in the light purple, and where there's no evidence for dengue risk in gray. The most important takeaway from this map is that much of the world has either frequent continuous or sporadic dengue risk. And while this is the current state of dengue risk, we also know that dengue incidence is likely to increase as the climate warms. These maps show environmental suitability in 2020 in the top, and then project this out to 2080, where we can see that the incidence is likely to expand geographically, but also with more intense transmission in areas where it's already present. In other words, dengue is and will be a big problem. So now, having covered the background in epidemiology, let's start in with the clinical management of this disease. We'll start by talking about the clinical classification of dengue. Then we'll talk about the natural history of the illness and how you can assess the phase of your patient's disease and their risk for severe dengue. And we'll also talk a little bit about the phenomenon of antibody-dependent enhancement and how that leads to plasma leakage. Plus, we'll look at some of the rashes of dengue. We will then talk about how to test for dengue. And finally, we'll talk about treatment according to the life-saving WHO guidelines. Before we talk about classification, I want to encourage you first to think about dengue when you're making your differential diagnosis. Anyone who might have been exposed in the last 2 weeks by being in an area with dengue risk could have dengue. It's important to think about it early because dengue, if left unrecognized, can lead to poor outcomes. So if you suspect that a patient might have dengue, you should empirically treat for dengue. So now, let's talk about how we classify a patient who we suspect might have dengue. The 2009 WHO Clinical Classification Guidelines define uncomplicated probable dengue as any patient who lives in or has traveled to an endemic area presenting with fever and 2 of the following: nausea or vomiting, rash, any one of a number of aches and pains such as headache, retroorbital pain, myalgias, or arthralgias, a positive tourniquet test, or leukopenia. Dengue with warning signs is a patient who meets the dengue clinical classification, plus has one of any of these 7 warning signs. They're on this slide, but I'm going to save those for later because this is the most important part to understand, and you should know how and when to screen for them. And finally, there's severe dengue. WHO has 3 ways that someone can be classified as having severe dengue. First, there's the most common presentation of severe dengue, which is severe plasma leakage, which leads to shock or respiratory distress. Second, there is the less common manifestation of severe bleeding. This is where the older name of dengue hemorrhagic fever comes from. However, because most severe dengue is actually due to plasma leakage, WHO is now trying to use the more general term of severe dengue. And third, it's any patient with evidence of severe organ impairment, since dengue can infect a variety of tissues, including the liver, brain, and heart. These are rare presentations of dengue, but they are by definition classified as severe. And these 3 classifications by WHO are very clinician-friendly because they roughly correspond to the triage for dengue patients. Patients with uncomplicated dengue, if they do not have any risk factors for severe dengue, can generally be managed as outpatients. Patients with dengue with warning signs should be admitted and given IV fluid administration according to the WHO guidelines. And finally, patients with severe dengue are typically managed in an ICU. So now that we know how WHO classifies this, let's get into how that relates to the disease course and our clinical assessment of a person with suspected dengue. I like to think through this framework for assessing patients that you can see on this slide. First, you have to think about dengue and include it in your differential diagnosis. If you're watching this webinar, then you've already done this part. Next, you want to risk stratify a patient. That implies understanding their phase of their illness, identifying any comorbidities or other conditions that would be risk factors for severe dengue, and finally, classifying it according to the 2009 WHO scheme as uncomplicated dengue, dengue with warning signs, or severe dengue. And to do this, it is critical that you systematically screen for the 7 warning signs at every clinical encounter, because catching one of those and preventing progression to severe dengue through protocolized fluid management could save a life. But before we talk about warning signs, you have to know when to look for these, which means that we need to understand the natural history of dengue. So after the incubation period, we think about dengue in 3 different phases: the febrile phase, the critical phase, and then the recovery phase. After a person is bitten by an infected mosquito, the incubation period can last from 3 to 14 days. After the incubation period, the first phase is the febrile phase, which is characterized by high fevers, aches and pains, retroorbital pain, headaches, dropping platelets, and bone pain. This phase typically lasts 2 to 7 days, and it's this phase where patients will typically present to care because they're worried about their fever. Notably, patients can be viremic and thus transmit the virus to mosquitoes that bite them from up to 2 days before the fever begins and through the entirety of the fever. Some of the clinical issues that can be seen during this period are dehydration, febrile seizures in children, and neurological disturbances. The end of the fever, or defervescence, marks the end of this phase and usually occurs on day 3 to 8 of illness. Dengue is unique because even though patients might be worried about their fever, it's actually immediately after the fever goes down that's the most dangerous period that we call the critical period. During this period, a patient will either improve or worsen, and by worsening, I'm referring to the development of capillary leakage or plasma leakage. Plasma leakage is the pathophysiologic process by which protein-rich fluid leaks from the vessels into third spaces and can result in ascites, pleural effusions, or even pericardial effusions. It can be evidenced by an increasing hematocrit or by the 7 clinical warning signs, which are evidence that this process is occurring. Although shock can develop due to plasma leakage, other complications like hemorrhage or severe organ impairment can also occur during this phase. If plasma leakage is occurring, the loss of intravascular volume can lead to hemodynamic compromise and can result in shock within hours. After the critical phase is the convalescent phase that lasts 3 to 5 days and is characterized by the reabsorption of the fluid back into the intravascular space. If the patient was given too much volume during the treatment of the critical phase, or even during the febrile phase, it can lead to volume overload, hence the importance of sticking to the WHO protocols. So I told you earlier at the critical phase that while severe disease can occur in about 5% of patients with dengue, it doesn't happen in all patients. So how can you tell if your patients are going to do well, or if they're at risk of decompensation and thus need to be admitted? And this is where the warning signs come in. Warning signs are 7 evidence-based signs or symptoms that are the early evidence that plasma leakage is occurring immediately after defervescence, a state that will not be good for hemodynamics unless volume management is pursued. These warning signs include intense continuous abdominal pain or tenderness, persistent vomiting, defined as greater than or equal to 3 episodes in 1 hour, or greater than or equal to 4 in 6 hours, fluid accumulation, including pleural effusions, ascites, or pericardial effusions, mucosal bleeding from the gums, nose, vagina, or kidneys, altered mental status, including irritability, drowsiness, or a less than perfect GCS, hepatomegaly, defined as greater than or equal to 2 centimeters below the costal margin, and finally, a progressive increase of hematocrit taken on at least 2 consecutive measurements taken 6 hours apart. If you can't remember them this first time around, don't worry. The image to the right is a clinician pocket guide that we created that helps you triage patients based on these warning signs and is available at the link below it. If you see one of these warning signs around the time of defervescence, don't wait. Start the patient on the WHO fluid management protocols and call for admission, because this patient is in for 48 hours of constant monitoring and fluid rate changes, because dengue is a dynamic hour-by-hour disease in this phase. So now that we've talked about the phases of disease and you understand the importance of systematically screening for warning signs at every encounter, let's review the high points. First, dengue is a dynamic disease and the presentation can change quickly, on the order of hours. That's why monitoring and identification of warning signs and criteria for severe dengue are key to risk stratifying and managing dengue patients. While patients are most likely to present during the febrile phase, plasma leakage and the slide into severe dengue occurs during the critical phase, which happens around the time that the fever goes away. And finally, another big takeaway is that shock and not bleeding is the most common severe dengue manifestation, which is why we have moved away from calling it hemorrhagic dengue. I want to take a quick aside to talk about antibody-dependent enhancement and how that leads to plasma leakage. Antibody-dependent enhancement of ADE is the phenomenon by which pre-existing antibodies lead to increased viral replication and worse disease. After a person is infected with dengue for the first time, some of the antibodies will cross-react with the other dengue viruses. When they are infected with the second dengue virus, those antibodies will bind to the virus. However, while they bind well enough to promote viral entry into antigen-presenting cells through the Fc gamma receptor, they don't actually bind strongly enough to neutralize the virus, which can lead to increased viral replication in the cells. And that increased viral replication means that there will be increased production of NS1, which is implicated in increasing vascular permeability and hence leading to plasma leakage and severe disease. And while severe disease can happen with any dengue virus infection, it's why we say that the second infection is the one at highest risk for severe disease. The graphic on this slide shows the sequence of a person being infected 4 times during their life. We know that the first exposure is at medium risk for severe disease. However, it's that infection that creates the poorly neutralizing cross-reactive antibodies. This means that the second time a person gets infected with dengue, represented by the person in red, makes it the highest risk for severe disease. After that infection, more broadly neutralizing antibodies develop, which is why the third and fourth infections are typically the lowest risk for severe disease. And when a patient develops plasma leakage, you will likely have evidence of this by seeing hemoconcentration on their labs. The strict definition of hemoconcentration is a hematocrit greater than or equal to 20% higher than the patient's baseline hematocrit, or a drop of greater than or equal to 20% following volume replacement. Pleural effusions or ascites can also be evidence of plasma leakage and can be detected on physical exam or a variety of imaging modalities. While the phenomenon of plasma leakage in ADE can be seen with severe dengue, any case of dengue can present with a rash, so let's take a look at a couple of common ones. One of the earliest rashes of dengue is flushing. This typically occurs right as someone is developing their first fever of dengue and is characterized by a sudden onset of erythema of the face, neck, and/or chest that might last hours or for the first days. There might also be mucosal involvement with pharyngeal, oral, or labial hyperemia. During the febrile phase, you might also see a more biliform rash characterized by macules or papules that start on the trunk and spread to the face and extremities. It can be scaly at times. Notably, it is typically a blanching rash. Finally, there is the classical textbook rash of an island of white in a sea of red. This typically occurs during the recovery phase. It's characterized by a confluent erythema with small round islands of sparing with the normal skin peeking through, giving it that island of white in a sea of red appearance. It's typically found on the lower extremities and can be quite pruritic. And let's not forget that there are also hemorrhagic skin findings. In fact, up to 30% of patients can be characterized as having hemorrhagic skin findings or minor bleeds, such as petechiae or purpura. Also, non-skin findings of minor bleeding can be present and include nose or gum bleeding or macroscopic hematuria. Don't forget that if you see these, they are warning signs. Finally, these small sentinel bleeds can sometimes harken worse bleeding that could be classified as severe dengue. such as massive GI bleeds that lead to prolonged shock and metabolic acidosis. These can happen so quickly that some patients might not even recognize the GI bleeding in the moment. So now that we're familiar with the clinical presentation, let's talk about testing and how that fits into dengue care. Dengue, like so many other infections, can have a non-specific presentation. This slide shows other illnesses in both the febrile and critical phase that might resemble dengue and show up in your differential diagnosis. And this is why dengue-specific testing can be very helpful in confirming the diagnosis. And while it can help to confirm the diagnosis, I do want to highlight that test results are unlikely to return within the time frame needed for clinical decision-making. This is why we always caution that for acute management of dengue, it should be based on clinical evaluation and not waiting for the laboratory confirmation. Appropriate testing is important for national public health to better understand the serotypes circulating in different regions of the world, but it's also helpful at the local health authority level to confirm local transmission in patients without travel histories and construct potential transmission chains between them and travelers, God forbid the outbreak grows. Also, health authorities direct their vector control interventions based on these laboratory-confirmed cases, so it helps with your local community response. In the event that you're testing for dengue, there are a couple of different diagnostic markers that can help you out depending on the point at which you test the patient. As you can see, dengue virus RNA, detectable by RT-PCR, and the NS1 antigen, the product of viral replication that we talked about earlier, are high within the first 7 days. The IgM levels start to rise around day 4 and will remain high for up to 3 months. And sometime after the first week, dengue IgG titers will start to rise and then will be positive for life. In the US, dengue is a nationally notifiable disease, which is why appropriate testing is so important for accurate and timely surveillance. Unfortunately, rapid tests are not widely available in the US at this time. Some commercial labs offer in-house laboratory-designed tests, including PCR, NS1, and serologies. However, we encourage all providers and healthcare systems to speak with their state and local health departments to understand the appropriate testing that they offer or recommend. But no matter who does your testing, the pathophysiology of dengue and when you collect the sample will determine the appropriate testing route. For patients who've had symptom onset less than 7 days ago, the viral RNA and NS1 will be high. And, as those decline, the IgM titers will be on their way up. That's why these individuals should be tested by either PCR and IgM test, or an NS1 and an IgM test. Using these test combinations, you can have a diagnosis in greater than 90% of dengue cases, with one or both of them being positive. Most patients present for clinical care and testing during the first 7 days when they have a fever, which is why these are the combinations that you'll be most commonly ordering. After 7 days, the test of choice to order is IgM, but you can also consider ordering an NS1 or PCR, because if those come back positive, it confirms the diagnosis. These tests don't suffer the same cross-reactivity as the IgM for other flavivirus exposures, like yellow fever vaccine or West Nile virus. However, it should be noted that sensitivity can be lower compared to days 0 to 7. I want to point out here that a single IgG test is never appropriate for diagnosing a person who is sick with dengue. In addition to virologic testing, you should always get a set of baseline labs on patients with suspect dengue, including a CBC, a comprehensive metabolic panel, and coags. The CBC in particular is important to draw at every visit, since these will help you evaluate for hemoconcentration, one of the warning signs of progression to severe dengue. Common findings on serial collected CBCs include leukopenia with a relative lymphocytosis seen on the top row of this graphic that can occur in the early, mid, or late febrile phase, a possible increasing hematocrit as the patient enters the critical phase seen in the middle blue bar, and a dropping platelet count in the late febrile phase seen in the lowest purple row. Finally, now that we've discussed the recognition, classification, and testing for dengue, let's talk about management. Overall, the standard of care for dengue is supportive management. There are no antivirals available. However, sticking closely to the well-validated WHO guidelines has been shown to reduce case fatality to less than 1% in randomized controlled trials. Don't forget that the most dangerous phase, the critical phase, is immediately after the fever falls, and that the most intense management of dengue will be during this time period. I always highlight this point because it's counterintuitive for patients and doctors. With most infections, defervescence is the moment to discharge, whereas for dengue, it's the moment where you need to be watching, testing, and managing patients most intensely. This critical phase only lasts for 48 hours, however, so once you're 48 hours without a fever and improving, you're in the clear. So if you've correctly classified your patients, management decisions are straightforward. WHO has said that patients with uncomplicated dengue and without risk for severe dengue can be managed as outpatients. WHO refers to them as Group A. Patients with warning signs or risk factors for severe dengue should be managed inpatient, Group B. And patients with severe dengue will typically be managed in an ICU, called Group C. And while I won't get too much into the details of each of the treatment groups, I do want to let you know that the pocket guide that I spoke about earlier has algorithms for all of these. The first page of this pocket guide has a triage algorithm and helps you work your way down the warning signs and risk factors for severe dengue to decide on a Group A, B, or C management. And the other side of this has quick management pearls for all dengue patients. And when you open the pamphlet up, there's a page for each management group, which tells you exactly what to do and how to counsel the patients. The images here are what the Group A, B, and C leaflets look like. So let's briefly go through them. Group A, or outpatient management, is for dengue patients with no warning sign who are tolerating PO and have a normal urine output. For this group, daily follow-up should be initiated as well as a daily CBC until they are out of the 48-hour critical period. Your healthcare team should work with the patient to monitor for signs of dehydration during the febrile phase, but should be particularly careful with monitoring and evaluation when the patient's fever goes away. It's during this time that patients should be educated to monitor for warning signs and return to care if any of them develop. The Group B patients include anyone with a warning sign and those with the risk factors for severe disease. For these patients, they should be hospitalized, protected from mosquitoes that might transmit the virus to other patients in the unit, and be monitored and managed. Strict ins and outs are a must, since the volume management algorithm by WHO is very particular about starting the algorithm and systematically marching down the IV fluid rate based on the clinical response of the patients. If they have warning signs or cannot tolerate oral fluids, then you can go to the WHO algorithm on the pocket guide and follow the steps. For example, the algorithm for a 60-kilogram patient with warning signs recommends starting by giving 600 cc's of isotonic fluid over 1 hour. And if responding to treatment clinically, then reducing that rate to 420 cc's per hour for 4 hours, then to 300 cc's per hour for 4 hours, and then to 150 cc's per hour until they're finally able to tolerate oral intake. Once they are 48 hours after the last fever without warning signs and meet all other criteria, they can be safely discharged. There are many fluid rate changes and frequent reassessments, but this fluid management protocol saves lives. Finally, Group C. Group C is for patients with compensated or decompensated shock, fluid accumulation leading to respiratory distress, severe bleeding, or severe organ involvement, basically anyone with severe dengue. For this group, it will be similar recommendations as for Group B to start, but you will refer to the Group C algorithm, which incorporates more aggressive IV hydration and some suggestions for the next steps should that aggressive hydration not lead to clinical improvement. For patients who are this sick, care will likely be individualized in an ICU. While your fluid management protocol should always be based on the calculations and following the WHO guidelines, there are a couple of overall tips that we can give you on this. First, limit IV fluid in the febrile phase. Most patients will be just fine with oral rehydration. Next, remember that most IV fluids are typically only needed for the 24 to 48 hours of the critical period. Also, even if you see hemoconcentration, don't forget that the reason is not a lack of free water, but rather because of massive plasma leakage. Do not give any hypotonic solutions like D5 or half-normal saline. Only give isotonic solutions. Also, remember that the goal of this resuscitation and the WHO algorithms is to give the minimum amount of fluid needed to restore intravascular volume, maintaining good perfusion and urine output. All of these fluid rate changes will require significant monitoring. For calculating the IV fluids, use the ideal body weight. Patients who are overweight or obese will be given excess fluids if you administer fluids based on the actual weight. Don't forget that all the fluid that you put into a patient will be reabsorbed quickly at the end of the critical period and can lead to significant volume overload if given too much during the febrile and critical phases. Finally, colloids such as albumin or dextran 40 are preferred if the blood pressure must be restored urgently, since they theoretically might increase the oncotic pressure intravascularly. If the patient is bleeding, use blood products and preferentially packed red blood cells. And while those are some of the do's, let's review some of the don'ts. Previously, it was thought that overwhelming inflammation from dengue could be treated using steroids. There is no evidence that steroids improve dengue outcomes. Do not use them. Do not use NSAIDs, which can increase bleeding risk. Don't give intramuscular injections. Life-threatening hematomas can develop if you give an injection to a patient with a dengue-induced bleeding diathesis. Finally, do not give prophylactic platelet transfusions. Once a hospitalized patient is feeling better, you can start to consider discharge. Patients with dengue can be safely discharged once they are 48 hours from their last fever, have stable hematocrits without IV fluids, have an increasing platelet count trend, and are improved clinically. I know we've covered a lot of ground today, but there are 2 important points I want to make. First, unrecognized dengue, leading to poor quality care and delayed treatment, is a common cause of death for patients with dengue. If we want our patients to get life-saving fluid management, you have to keep dengue in your differential diagnosis in all patients with recent travel to areas with dengue risk and in those with compatible signs and symptoms. And the second point is that you should screen for warning signs at every visit, educate your patients on them, and be particularly vigilant around the time that the fever goes down. These signs and symptoms of plasma leakage are critical in identifying those patients that might progress to severe dengue and thus will need to be hospitalized to start the WHO fluid management protocols. Building your clinical foundation in dengue management is an essential step towards reducing dengue morbidity and mortality. We covered a lot of information today, so here are the main takeaways we hope you remember. First, think about dengue. If a patient has a possible exposure history or presents with compatible signs and symptoms, keep dengue in your differential diagnosis. Second, always screen for warning signs. These signs predict progression to severe dengue and can help determine who should be hospitalized and who can be managed as an outpatient. Finally, follow the guidelines for management. CDC's website offers resources, including pocket guides, with all the information you'll need for effective management. Thank you for watching this training and for helping to keep your patients and their communities safe from dengue.